Thank you, Mr. Chairman, and thanks for holding this hearing. And obviously, the rollout of the Mission Act has been widely watched by veterans across the country, certainly in my congressional district. Thank you to former Chairman Miller for your efforts in kind of laying the groundwork with the Choice program. And I don't think we would be here without, I would echo our current ranking member, and we wouldn't be here without those first steps. But as the former chairman knows, and as Dr. Rowe knows, we did have problems with provider payments under the Choice Act, and confusion over the different authorizations and difficulties with referrals made the Missions Act passage a necessity. To all our panelists here today, thank you for the work that you do to serve our veterans. And let me start with an anecdote from one of my constituents. I represented a veteran who had difficulty using the Choice program. He experienced significant delays in obtaining community appointments for cardiology and neurology. And the finger pointing that Mr. Golnick described is precisely the problem with the referral system that my constituent experienced. He was told by the VA that his case was referred to the TPA, but when he didn't hear from anyone, he contacted the TPA, who then told him they did not have his medical records. When he called the VA back, there was some confusion, but ultimately we were able to help him and discover that the delays were due to a failure by his VA primary physicians to submit his consults to the third-party administrator. Meanwhile, precious time had passed, delaying care longer than if we think my constituent had just stuck with the VA and not even attempted to use the Choice program. And so we hope that as we transition to Mission, that kind of a scenario would never happen to my constituent or any other veteran. And so I'll start with Dr. Matthews. How confident are you that as we transition away from Choice and into the post-Mission Act world, that scenario that affected the veteran that I represent will never happen again?
If you don't mind, I'll actually defer to my colleague. We actually do have an approach to this issue.
Yes, sir. And if you would be willing to share that veteran's information with us, I'd like to make sure that that care has been delivered now and that that veteran has everything he or she needs. The approach we're taking to this, and as I mentioned earlier, we are delivering urgent referrals within 2 days. We're actually at 1.4, and that number continues to improve. That's better than the private sector, and we're proud of that. Where we have work to do is in routine referrals. And this has been traditionally a fragmented and antiquated process with the technology underlying it that has been also antiquated. What we are bringing ourselves to is in line with industry best practice, which is we are standing up referral coordination teams, wholesale transforming our process. And when a veteran leaves that primary care visit, you have 2 primary care clinicians here, when that veteran leaves a primary care visit or sees us via telehealth, immediately there's a team to engage that veteran and make sure they know the next step in their care, that care is referred, processed, and that care is delivered. Our goal is to have all of these teams in place in every specialty by July of this year, and our goal is 3 business days or less for the processing.
Great, thank you, and we will double check. I think that our veterans' issues were dealt with, and he did get the care, but we'll circle back to make sure, and I appreciate the offer.
Thank you.
General Horojo, as Region 2 in my district transitions from Tri-West to Optum, ensuring an easy transition for the veterans I represent is a chief priority. As far as providers go, can you describe how you are deciding who to bring into the Optum network if the current United Health network does not meet access standards?
Thank you, sir, for that question. So the first is to look at the 1.3 million providers that we have across United. We also then look at the data on capabilities that we may need to bring in. We get a preferred provider list from the VA on those preferred providers that either the VAMC is used to using or Veterans High Referral Rate. They give those to us. We then reach out to those providers, and then we've also had members of Congress recommend different providers. We look at the big academic universities to bring those in as well.
Yeah, that's great, because I know the University of Kentucky Health System currently has a great relationship with the Lexington VA. They even share a medical bridge between the buildings, and we hope that you would be looking at facilities like these to incorporate in the network.
And yes, sir, we are.
Great, very good. And also, are you working with Tri-West to see what facilities have been seeing high volumes of veterans under their contract?
Yes, sir. We have weekly meetings with TriWest and with the VA and really look at the referral patterns, lessons learned, and so we're working very, very closely with our teams.
Great, thanks so much. And again, I think we're making a lot of progress with the Mission Act. I appreciate all of your participation and implementation. Thank you. I yield back.